This one actually is a really, really good plastic surgery topic, and it's something I know a lot about, and it's about breast reconstruction. And man, this is going to piss off some plastic surgeons. Like if this gets around, there's some plastic surgeons going to be mad at some of the things I'm going to say, but it's something I've been saying for like a decade. So what this is about is a recent article that came out that was talking about the potential changes to the insurance reimbursements for certain types of breast reconstruction. So that says autologous, so that's basically when you're using your own tissue to do reconstruction. And they've had surgeries like that for decades. The first two big ones were the tram flaps, which is using the fat from your tummy and the muscle to rotate up, and the latissimus flap, which uses fat and muscle off your back to like rotate in. And so the autologous reconstructions have been around for forever.
Yeah.
And you know, and kind of looking at the history, like when I started plastic surgery in the mid 2000s, reconstructions weren't phenomenal. Like, you know, they were starting to get a little bit better at that time, but in the years previous to that, most reconstructions were just, let's get something on the chest so that when a woman, you know, puts a bra on, you know, these are after mastectomies, right?
Yeah.
So just to clarify, these are after women gets mastectomies. You know, the reconstruction was just trying to get something there so they could wear a bra and look normal in clothes.
Yeah.
So technology started getting better in the mid 2000s, and we started using the expander balloons to inflate the skin to kind of restore that shape, and then we were using silicone implants. And also a thing that really helped is the surgeons doing the mastectomies learned that they didn't have to go crazy removing tissue like was done in the 80s and 90s. They used to call it a radical mastectomy because it would take all of the skin, all the breast tissue, the muscle, the nipple. I mean, just everything was just gone.
Yeah, that's how my grandmas were.
Really? Yeah.
Yeah.
So when you do something like that, reconstructing something when there's just nothing left is really hard. So what made a big difference in the reconstruction is the surgeons doing the mastectomies learned, hey, we don't have to do all that to get people cancer free. And so that kind of like was becoming a thing right about the time I started plastic surgery in the mid 2000s, and they started doing what's called skin sparing mastectomies, where instead of taking all the skin, they left as much skin as they could. And so, you know, the quality of the reconstruction started to really improve in the late 2000s and the early 2010s. And then they started doing nipple sparing mastectomies, where we just make an incision and just hollow out the breast to take out the cancer and leave everything. And then, you know, I was getting some reconstructions that literally look like breast augmentations.
Yeah.
They look beautiful, and I probably should have brought some pictures, but if anybody's interested, I can post those. But then what happened is it started coming around in the late 2000s as well. A new type of autologous surgery came out called the DIEP flap, DIEP, which is just an acronym for the blood vessel, the deep inferior epigastric perforator vessel that supplies it. And so instead of taking the muscle, which has the blood supply, and the fat, people just started taking the fat and then the blood vessel and then hooking it into a blood vessel in the chest. And we called that a free flap or a free tissue transfer, where you're actually cutting the blood vessel, and then instead of rotating it on its blood vessel, you cut it off and then you sew it to a different one to supply the blood. And so I did a few of those in training, and I didn't really ever like them. I mean, one, you know, that's a super, super complex surgery. And then usually when you do reconstruction, you want to start with the simplest plan, not the most complex. But the other thing that was a problem is that the results were never that great. And that's not just like what we were doing, that's everyone. The results are just not phenomenal with them. And then there was a lot of potential complications with it. Yeah. So I never really bought into the DIEP flaps. I just thought that they were...
I would think the way you described it, you could like see the like the difference in skin.
You can. I mean, that you're right, and that goes along with any type where you bring in skin.
Yeah.
I mean, that you can see that when you do like a lat flap from your back or whatever. But you know, my biggest gripe about them was that one, the surgeries took forever. I mean, if you're doing one by yourself, like a bilateral one, it would take 8 hours. I mean, it's a huge OR
you're
time.
talking about like connecting.
Yeah, like you're connecting
vessels.
blood vessels using a microscope to do it, and then there was the risk of the flap dying, and you know, and like the results were not great. And so when I left my plastic surgery training program to go to my breast fellowship, I worked with a guy named Dennis Hermann, guy's like legendary, world famous plastic surgeon. And so I asked him about it because this is, you know, they were starting to pick up a little bit of steam at that time. I was like, what do you think about these? He's like, yeah, I don't think they're that great. And I was like, oh, cool, I don't think they're great either. And so we were kind of in agreement, which I thought was neat. So fast forward to kind of the mid 2010s, these things started to really increase in popularity. And I got a couple, I think I have some little infographics. So this this is just showing by year reconstruction, and all this one shows is that reconstruction from 2008 to 2020 was increasing in popularity, which makes sense. The technology was getting better, we could get better results, so the increase in reconstruction was expected. But go to the next one, Travis. That's the one I really want to show. Okay, so the blue line is the DIEP flap, the DIEP flap, and the other lines are actually the other autologists. So not the way I generally do reconstructions, but the other flap type procedures. And look what happened in 2018. Like there's a steady increase from 2010 to 2018, but in 2018, the use of these flaps went through the roof. And I'm gonna ask you guys, why do you think that was? And if you don't,
I'm guessing they made some type of new technology that was available, and so they were able to do it faster and cheaper.
Well, you're on the right track. It was money.
Oh.
So what happened is people realized that the way that you code these flaps, okay, a surgeon could get reimbursed $10,000 or more for a single surgery. And even more crazy is the hospital. I looked this up, pulled the data on what was the average hospital charge for somebody who got a DIEP flap. You want to take a guess? How much? Throw a number out there.
20,000.
$100,000. $100,000.
Oh, well, you said it takes 8 hours sometimes.
Right. And so people started realizing, and this is the part that'll piss people off, is suddenly this flap, which I never really thought was a great way to do reconstruction, became insanely popular because people were getting a lot of money from doing it. In fact, the hospital where I worked at, where I was doing a lot of reconstruction, really kind of brought someone else in that would do the flaps because I wouldn't. I was like, look, I'm getting results that look like a cosmetic surgery in a case that takes 2 hours, and it only charges the patient a small amount of money. Why in the world would you do this?
Yeah.
Well, money. And so what happened was, I basically kind of quit doing reconstruction as much because I wouldn't do these flaps. And
was
so,
there any benefit to it at all besides?
So I mean, if you want to really be technical, the benefit of doing that flap over doing the way I do it, which is expanders to implants, is potentially you could do it in one surgery, which never works out because all those DIEP flaps almost always require revision. But the other thing is you avoid having implants, which people get implants all the time. Like it's not that big of a deal. I guess really the biggest advantage of the DIEP over the expander to implants, which I do, is if you have a girl that's larger, sometimes you can run into a problem with the expander to implant that even with the biggest implant that you have, it doesn't fit their frame. And for those girls, they're obviously going to be a little bit fluffier around the center. You can actually get a pretty big reconstruction with the flap. And that's really the only time that I feel like that they're an advantage to do. And I actually have sent patients out. If I get the right patient where I'm like, look, you might consider doing this flap, I'll actually send them to somebody that does them.
Yeah.
But the problem is people were using them for every patient.
Yeah.
Because money, right? And so I said this when it became clear what was happening. I was like, what's going to happen is insurance companies are going to figure this out, and they're going to stop paying all this huge amounts of money for this, and then suddenly no one's going to do DIEP flaps anymore. And I was talking to a general surgeon friend of mine just a few months ago, and she said, yeah, the plastic surgeons now are talking people out of DIEP flaps. And I was, I wonder why that is. Well, it's because of that article that was posted. So what the article is saying is that the insurance companies are changing how these things are coded, and they're not going to pay these huge amounts of money for them.
I guess there has to be like special circumstances now.
Yeah.
Like real circumstances.
So it's just funny that, not to say I was right, but I was right. Like what happened is that people started doing these and the insurance companies realized that they were paying huge amounts of money for these, and it's like not a moss.
You called it.
Yeah. So of course we're not seeing that downtick yet, although anecdotally we are, because I had a surgeon tell me, hey, they're trying to talk people out of these now. Because for a while everyone was pushing them. And and it's the thing with patients, like, you could talk a patient into anything. If I have 3 patients, I could talk to these 3 patients and talk them into 3 different surgeries for the same thing, because patients rely on you. So it's how you explain things. So it's easy to talk these patients into it, and then there was a lot of buzz about it. But now it hasn't happened yet. But in the next year we're going to see a downtrend in these, like a huge downtrend. Because I was looking at the numbers. So in 2010 they did 5,000 DIEP flaps. In 2020 they did almost 25,000. The number just went through the roof.
Yikes.
Yeah.
But new data.
New data, right? Well, it's just the insurance companies. Like
Yeah.
they're saying that it's not they're not going to pay for it anymore. Which I'm totally for this. I mean, as I said, I believe in doing the simplest thing that you can do to get a good result without making these over complex. And people are getting great results with these expanders to implants. Like like I said, I have photos of people in my office, and if you looked at it, you'd be like, oh, that's a breast augmentation. Like, nope, that patient had total mastectomies, and we just got this really nice result for them.
Yeah.
So yeah, it'll be interesting to see how it all plays out. I still do a little bit of breast reconstruction. One of the biggest reasons I don't is the girl that I was doing, or the doctor I was doing most of them for, she started slowing down and not work as much. And when they brought in a new person and they wanted the DIEP flaps, I was like, yeah, no, I'm not interested. So interesting stuff. Yeah.
Well, I'm sure that they're changing
Yeah.
their ways.
Yeah,
now.
it was funny because, back when I was in plastic surgery training, really not a lot of people want to do reconstruction because it doesn't pay a whole lot. I mean, it's true. Like when I do a reconstruction, I think that I was getting reimbursed, somewhere
Well, that's
between.
because you can use insurance with reconstruction.
Right, absolutely, yeah. But I was getting reimbursed, like, maybe $1,500 to do these reconstruction cases. But the thing is these patients are more prone to have problems. It's the nature of the beast thing. You take out the breast, it really kind of injures the site, and so they're more prone to infections or breakdowns. A lot of them get radiation therapy, which also is really bad for surgery and healing.
Yeah.
And so, when you do a lot of reconstruction, you have patients that, have to go back to surgery, or you have to see them on the weekends. And so nobody wanted to do it back then. And I did it because I liked the challenge of it, and I liked helping people. And but what's going to happen is now that the money's drying up, then no one's going to, it's going to be a thing where not a lot of people are doing it anymore, which is sad. I probably will end up going back to doing it at some point. But interesting stuff, yeah, because it is going to change a lot. And so you're going to see in the next year or two the number of these flaps just kind of bottom out. Because why would you, if they're doing it for money and the money dries up, like they're not going to keep doing them.
I mean, to me, even though I'm not a doctor, it just sounds like if you don't need it, then why are you doing it situation.
I mean, that happens a lot in medicine, honestly. I mean, unfortunately, medicine is just like, any other field where at the end of the day,
it's a business.
It's a business, right? And people make decisions based on money. And,
yeah.
I try not to do that. I feel like there's enough money to be made by, doing the right thing. But, not everyone thinks like that.
Yeah.
So anyway, interesting stuff.